Honorable Chairperson, Panelist, and audience, good afternoon. My topic is Novel Innovation Made Complex PCI Simple. I have nothing to disclose. KH, 65 years old, female, hypertensive, diabetic, dyslipidemic patient, ESRD on mechanical hemodialysis 3 per week, complaining mainly of effort angina class 2-3 for last few months. She had a history of fall prior to admission. ECG showed normal and echo there is no RWMA and EF is 60%. CT scan brain showed mild subfalcine hemorrhage with resolved in repeated CT. Carotid duplex showed mild diffuse atherosclerotic changes in right carotid arteries. And CAG showed critical calcified TVD. Left main is calcified and normal. LED type 4 vessel, diffuse calcified vessel has got 80 to 90% stenosis at its proximal to mid segment. Diagonal branches are small and ostial disease. And LCX is good size vessel, calcified, has got 60 to 70% stenosis at its mid segment. OM2 is reasonable size vessel with mild disease. And RCA dominant vessel, calcified, has got 80 to 85% stenosis at proximal to mid segments, followed by mild plaque at distal segment. And what will be the treatment option? After heart team discussion, decision was made to go for PCI with IVL as CABG refused by surgical team. Patient party agreed with us and we went for PCI. LCA was engaged with the guiding catheter EBU 3.5 6 French. The Sion blue wire was crossed, the lesion of LED, and dilated with 2 into 15 balloon at 10 to 14 ATM. After pre-dilatation, I was done, and I was shows severe calcification, concentric calcification. And the calcified segment was dilated with IVL support using 2.5 into 12 millimeter balloon. IVS is continuing. There. IVL continues from distal to proximal segment. And after IVL, IVA study was done and calcified area was well prepared for stenting. Due to time constraint, I am not showing the IVAS fully. And then mid to proximal LED was stented with 2.5 into 38 millimeter DES at 12 to 14 ATM. And overlapping the previous stent and covering the proximal lesion with a 2.75 into 32 millimeter DES at 12 to 16 ATM. And post dilatation was done with 3 into 10 millimeter balloon at 12 into 18 ATM. And the final angiogram showed LED was well dilated with T-mid 3 distal flow. This is the post stenting IVAS showing both stents were well opposed. After the PCI to LED, patient suddenly developed acute left ventricular failure. For this, PCI to RCA postponed. Patient sent to CCU for stabilization. Immediately dialysis started, And after few days, patient became stable, and then we proceeded further for PCI to RCA. And then RCA was engaged with the guiding catheter JR 3.56 French. The Sion blue wire was crossed, the lesion of RCA, and pre-dilated with 2×15 balloon at 10 to 14 ATM. After pre-dilatation, I was done and found the concentric heavily calcified vessel. Then the calcified segment were well dilated with IVL balloon 2.5 into 12 millimeter. IVL continuing. And after IVL, IVA study showed calcified area was well cracked. I am not showing the full IVAs. Lesion was stented with 3 into 34 millimeter stent at 12 to 14 ATM. And post dilatation was done with 3.5 into 10 millimeter balloon at 14 to 22 ATM. And after post dilatation, IVA study was done and showed stent was well apposed. Final angiogram showed RCA was well dilated and the previous LED stent is patent with TIMI3 distal flow. This is the IVL system. And in conclusion, considering the age, comorbidities and extent of calcification, it was a very complex and high bleeding risk patient to deal with. But with proper planning and use of appropriate technologies, we have overcome all the hurdles. And in take home message, calcified lesion is always a challenge for the interventionist. New innovative technologies are becoming available to make the interventions easier. All armaments should be ready in the cavalry, and patience is the key to success. Patients are the main center of focus. Thank you. Thank you for your patience hearing.